Good afternoon, good morning, good evening. Welcome to today's webinar on addressing priorities in HIV testing, optimizing service delivery in sexual health clinics. Today's webinar will focus on HIV prevention in sexual health clinics, both in EHE and non-EHE jurisdictions. This webinar today is a part of a webinar series. This is the second webinar, and we will also be sharing information on how to access the previous webinar during the next couple of minutes. We will be sharing the recording from today's webinar, and that will be available through the RAISE and NASTAD website. So a little bit about RAISE and NASTAD. RAISE is the Research Alliance and Implementation Science to End HIV Hub. That is a part of the University of Washington CFAR. And for those of you who may not be familiar with NASTAD, we are a national organization representing public health officials in state health departments, as well as the U.S. territories. And we are also the national technical assistance provider for ending the HIV epidemic, or EHE initiative. You can learn more about our work, as well as the work of the RAISE Hub, on our websites. We also encourage you to reach out if you would like to speak with the RAISE team about how we can support your HIV prevention and care work. And so I will put all these links in the chat in a minute. We also want to just make you aware our final webinar in this webinar series will be on April the 23rd, and we'll be focusing on how to engage healthcare organizations for HIV prevention and care. So we're very excited to welcome our panelists for today. We will have our panelists first present for a few minutes each, and then we will have time for Q&A. So please feel free to use the chat and the Q&A function to put in your questions at any time. So our panelists today include Dr. Julie Dombrowski, who is the professor in the Department of Medicine at the University of Washington. She's also the deputy director of the HIV STD HCV program at Public Health Seattle King County. We also have Dr. Joseph Cherabie, who's the assistant professor in the Division of Infectious Diseases at Washington University in St. Louis. We also have Dr. Wesley G. Willeford, who's the medical director of disease control at Jefferson County Department of Health in Alabama. And finally, also Dr. Rachel Harold, who's the supervisory medical officer for the HIV/AIDS, hepatitis, STDs, and TB administration at DC Health. So welcome to all of our panelists, and thank you all for joining today. I'm going to pass it off to our first presenter today, Dr. Dombrowski.
Thank you so much, Krupa. And I do not have slides, just so folks know that. It's really exciting to be here today and talk about improving services in sexual health clinics. I want to talk just briefly about the rationale for focusing on sexual health clinics, the funding that supported some of the efforts you're going to hear about, and then tell you a bit about our work in King County. So sexual health clinics are crucial to ending the HIV epidemic for several reasons. First, and perhaps most obviously, patients in sexual health clinics have or are at risk for STIs, and therefore generally also are at risk for HIV, and it makes sense to have integrated prevention and care services. Second is equity. Sexual health clinics disproportionately see people who are members of racial ethnic minority communities, and in many areas serve as a sort of safety net clinic and disproportionately see people who are uninsured and may not otherwise have access to health care. And third is that many sexual health clinics really function as specialty providers for sexual and gender diverse populations and really have specialized knowledge about providing culturally competent or humble care to those populations. So enhancing services in sexual health clinics really can help us reach the populations that we need. And these clinics are so often under-resourced for providing services. So CDC did provide services to sexual health clinics and to some of the speakers you'll hear from today through a mechanism called Component C, which was essentially part of CDC funding really specifically to enhance HIV services in sexual health clinics. And then the Minority HIV/AIDS Fund also contributed funding for prevention training centers to enhance TA and work with other clinics who weren't funded by Component C to improve services. For us here in Seattle-King County, our sexual health clinic was not one of the Component C recipients, but we worked with our local PTC and our other colleagues around the country, many of whom were Component C funded. And at the beginning of this process, we had really pretty robust HIV testing in our sexual health clinic. The main thing we need to do to improve there is increasing throughput, improving express care. We had a pretty robust PrEP program, really with a demedicalized model that I'd be happy to talk more about if people are interested, where DIS really do most of the PrEP visits and delivery, with providers only seeing patients at baseline and at 1 year. And similarly, we have a relinkage program for people with HIV who come into clinic and haven't been engaged in services. So a lot of our work for this really focused on PrEP and enhancing and improving our programs. First, we got monitoring into place to really understand where our fall-offs were and monitor that over time. Second, we know that we have a fall-off and always have right at the point of initiation, where people have a first visit for PrEP, but then don't necessarily start it. So we tried offering PrEP in hand, recognizing the opportunities when TDF FTC became available in generic form, and are still evaluating the extent to which that helps improve initiation. We also started a PEP program in our clinic, which we had not previously had. We had worked with an HIV clinic nearby, but recognized an opportunity not only to provide more client-centered services for people who need HIV post-exposure prophylaxis, but also for that to serve as an entry point into PrEP for people who may benefit from it. So I'd be happy to talk about any of those topics in the question and answer session, and I'll turn it now over to our next panelist to talk about their work. Thank you so much. Joseph, I think you're next.
Yes, I am. Thank you so much for having me here today. And thank you, Julie, for not having slides, because I also don't have slides. So that was great. That makes me feel so much better about myself. First off, my name is Joseph Cherabie. I use he, they pronouns. I am an assistant professor at WashU in St. Louis, but I also was previously the associate medical director of the St. Louis County Sexual Health Clinic, which I passed on to my colleague, Dr. Donald Hong, and work closely with Dr. Hillary Reno and Dr. Donald Hong in managing the PrEP side of our St. Louis County Health Clinic. I also am the medical director of the WashU PrEP Clinic. And so I really appreciate the overview of all of the different funding mechanisms that were introduced in order to help increase PrEP and HIV prevention, as well as testing services within the St. Louis Sexual Health Clinic. So our clinic was a Component C clinic. We were one of the first people who were awarded Component C funding. And of course, that came at the time of COVID-19, where a lot of us were basically quite busy, and a lot of our resources were being shuttled off towards other things. But we finally got to get a lot of our work in play, which is really fun. So just some context for you about what our clinic looks like. We are a no-cost clinic. We are also a Title X clinic, and we also have Component C funding. We are an interesting clinic that serves North St. Louis, which is predominantly Black. 90+% of our population is Black, and then majority of our patients are actually heterosexual, which again makes for an interesting means of trying to implement HIV testing as well as HIV prevention towards to a population which has historically not been the primary focus of many of our HIV prevention mechanisms, right? And so one of the things that we initially wanted to do, especially to increase uptake, we had individuals who were on PrEP prior to COVID. We had a collaboration with one of our local pharmacies, where our pharmacy actually took care of most of the PrEP follow-up. And so it was a pharmacy-based PrEP model, and they did a lot of the testing afterwards. We did the initiation and referral. However, during COVID-19, a lot of that was upended. We ended up moving towards a teleprep model for initiations. And then after, around 2 years into COVID, we had our 340B pharmacy at WashU open up. And so we ended up making a collaborative practice with our WashU clinic. And so all of our patients who enter through our door are screened for interest in HIV PrEP. They are asked if they've ever heard of PrEP, if they are currently on PrEP, and if they are interested in PrEP. And that's all on intake. And so I can tell you from that, we've seen a massive increase in the amount of individuals who are being screened and spoken to about PrEP through our clinic. All those patients will be seen by our PrEP navigator, which we hired an in-house PrEP navigator. Our PrEP navigator is one of the most magical people I've ever met and worth her weight in gold. Basically, our PrEP navigator has helped us to get to a point where we had 300 people referred last year for PrEP and over 100 people that stayed in-house within our clinic to provide PrEP care. With that in mind, a part of our funding went to actually make sure that people get PrEP in hand same day. And so we have starter packs of 7 days of TDF FTC, which we provide to every single patient who is interested in starting on PrEP. And that, of course, gives us a head start by the time they deal with all of the paperwork for payment assistance, as well as making sure that they have coverage for further PrEP options. If they are interested in injectable PrEP, of course, we will refer to our WashU academic clinic because our injectable PrEP goes through there. But it's a two-way model. We've created a kind of regional hub of resources in order that all of our regional partners know where they can refer people. And seeing as this is a no-cost clinic, and seeing as Missouri happens to be the state with the lowest amount of insurance that lists HIV PrEP as a preventative benefit, we deal a lot with laboratory cost issues in our academic medical center. And so a lot of my patients come back saying that they have bills for $800. We play, guess the billing code, or what I call billing code bingo, in order to try to make sure that we get the costs covered. And if it becomes a consistent issue, we refer actually to our sexual health clinic in order to run a lot of those labs, because again, it is no cost to do so. And they have great collaboration already between our PrEP navigators in my WashU clinic, as well as in the St. Louis County Health Department. Now, the other thing that has been really unique that we've instituted is that we are allowing our DIS and basically training our DIS in order to do blood draws in the field and to do rapid syphilis and HIV tests in the field. The DIS also will detail anyone on HIV PrEP, and anyone who is interested does get our PrEP navigators card where they can call or come in. But that the rapid syphilis and HIV tests in the field is primarily focused on individuals who are sexual contacts, of course, who are listed in a DIS investigation. But we have a big focus as well as individuals with pregnancy potential, as well as individuals with a history of rectal gonorrhea or chlamydia, because we know that those individuals may also have an increased likelihood of HIV acquisition. So having those rapid tests in the field has been quite a game changer and has honestly helped us to do quite a bit of work, which is really great. And having them linked to our PrEP care has also been really helpful. We've referred over 100 people. We've had 5 PrEP starts, but again, this is a relatively new program. And still, those are people that might not have walked through the door otherwise. So that's really, really exciting. And so I'm happy to talk about any of these programs with anyone afterwards in the Q&A, but I will pass on to our next panelist. I forgot who the next one was. I'm sorry.
I think it's me.
Okay, yay, Wesley.
Hey. Hello, everyone. My name is Wes Willeford. I use he, him pronouns. I'm the medical director of disease control at the Jefferson County Department of Health in Birmingham, Alabama. I do not have slides either, so I just wanted to talk about a few things that we are doing right now that I'm very excited about. I want to give just a little bit of background on Jefferson County, Alabama. So we have about 665,000 residents in our county. Our clinic, the JCH Sexual Health Clinic, we see about 20,000 patients each year that's spread across 3 clinical sites. Our clinic is composed of myself, 11 nurse practitioners, 3 public health nurses, and about 19 disease intervention specialists. So we have quite a team of people to help take care of the people in our county. One of the challenges that we ran into when I came into this role in July of 2019, I did a few walkthroughs with patients just to see what the patient process was like. And what I noticed very quickly was a lot of patients were coming in to see our providers for sexual health testing only. They really didn't have a complaint. They didn't have something you could point to as a symptom or as a physical exam finding. They really just wanted testing. And that really, when I started talking to my providers, that became a recurring theme. Like, oh yeah, half the people I see are really being seen because they just want sexual health testing. This sort of had some backup effects. One thing that what we really noticed is that so we unfortunately over the years we've had to maintain a policy where we do same day scheduling. What we've noticed is if we put the scheduling too far out, we have a tremendous number of no-shows. So that has been one constraint that our clinic has worked under. But what that results in, whenever you don't have a lot of appointment slots, is people waiting on the phone for a very long period of time trying to get an appointment, and sometimes in excess of 20 or 30 minutes before this process was instituted. And that really was something I don't like. I want a good patient experience from the phone call you make to the clinic until you get your results back and whatever actions are taken. So what we ended up doing to try to address some of this is we created this fast track process, is what we called. I think other people have used the term express visit. I think that's just what we ended up settling on. And the fast track process really is meant to be an to get sexual health testing, so HIV, RPR, HIV, syphilis, gonorrhea, chlamydia, trichomoniasis testing, so that people can get that quickly, and especially for persons who are not actively having symptoms. So what we envisioned to make this happen, we said we want to utilize all of our staff to the best of their ability. So the first group of staff, the first contact point for the patient would really be our public health nurses. So once a patient was scheduled to a fast track visit, a public health nurse would reach out to the patient. They would perform a symptom screener just to see if there was anything else going on and make a determination if the patient is appropriate for a fast track visit. If they were, they'd be placed on the schedule and the patient would be allowed to come in. If they weren't appropriate, the patient would be given an appointment to see a provider. So it would still be a pathway to get the patient's issues taken care of. When the patient would come in, what would happen, that they would check in, then a disease intervention specialist would come to bring the patient back and talk with them. Of course, our disease intervention specialists are excellent at providing education on various sexual health related topics, including PEP, PrEP, DoxyPEP now, and they're able to provide that education along with drawing labs for the patient in the clinic. The other thing that we were doing prior to 2023, the DIS were giving patients instructions on how to perform self-collection for multi-site STI testing. I'll come back to that in a second. But that allowed the patient to sort of control the process, control the testing, and really be able to make this as easy and quick as possible. And the benefit, two other major benefits. One is it's usually less than a 15-minute visit, and all of our visits at our sexual health clinic are $5, and that's something that we do not chase people after if they're not able to pay it. We really want that to be a very accessible service to anyone who comes here. So when the model was rolled out, really our first year was in 2020, and we did a few visits in 2019, but really 2020 was the first year we got it off the ground. Really to a great degree of patient satisfaction. We had about 888 patients that were seen that year. As we moved through the years, we've taken that up to 2,243 patients as of 2023. So that's something that we've been working on expanding. But I think a lot of that expansion has come through one major innovation that we put into the system in 2022, and that was an online self-scheduling portal where patients could go to our website, make this appointment, and really be able to, wherever they are, they can make this appointment. That's also allowed us to advertise a bit more effectively because we could put out a QR code or a web link, and the patients could go straight to the site to be able to schedule that. And that's something that I think our patients have responded very well to. A couple other things about this is, one thing I say commonly is that, these visits really are only going to be worthwhile if we have a relatively low percentage of patients who actually end up being reactive for other STIs. And so the numbers that we've had over the past few years, on average, about 3% of these visits will have someone who's positive for gonorrhea. About 7% of the visits will have someone who's positive for trichomoniasis, about 7% for chlamydia, and about 1% of those persons tested would be positive for HIV. So that's still higher than we want, certainly with HIV. But overall, a relatively low percentage of people coming through fast track actually end up having an active STI. So Where this has really been beneficial for us, it's allowed our providers to be absolutely as efficient as possible. We're wanting them seeing patients who have an active issue that needs to be intervened upon, where there's physical exam findings, where there's a complaint that can be evaluated, and we can evaluate and treat a person as quickly as possible, with the particular hope of having a greater impact on our local local STI epidemiology. So what is the future of our fast track screening? So fast track is absolutely here to stay. This, again, this has been one of the major things that's been funded through Component C, helping us to expand this and make this a sort of a pillar of our clinical operations. And even though the Component C funding is going to be leaving us in the next, oh gosh, that's coming up quickly, by the end of May, it's something we're still going to be able to do. It's something that we're very committed to doing. And I think it's something that our patients absolutely expect at this point. And it really has allowed us to lean into a paradigm of promoting sexual wellness and just general sexual health and maintenance of sexual health, so that people know that they have this resource available to them. If they feel as though they need to have testing more frequently, we're here for that. We want people to be able to utilize that service easily and affordably. And it also gives us a lot of opportunities to talk about PrEP, PEP, and DoxyPEP, and let us really let our DIS provide this information, or let our nurses provide this information to patients, and hopefully link them to those services as we continue to combat our local increases that we've seen in things like syphilis and gonorrhea. Lastly, I'll say that one goal that we're aiming towards is we do want to have a capacity for walk-in visits. So far, all of our appointments are scheduled only. And a lot of that kind of came out of pandemic constraints that we ran into. Lots of complaints about when we did multiple bookings or had lots of walk-in visits, patients were waiting much longer than they wanted to. Perfectly understandable, but a lot of patients are under time constraints to get back to work. And we really want to aim to honor their time as much as possible. But I think with Fast Track, we may have some capacity for walk-in visits, really to allow greater accessibility. So that's all I really have to say. I really appreciate the opportunity to be able to speak, and I'll turn it over to Dr. Harold.
Thank you so much, Wes. That is very cool to hear about. I did prepare some slides, but that's not feeling very retro. So I'm just going to tell you all about what we do here at the DC Health and Wellness Center. So the DC Health and Wellness Center is the only direct service provider operated by DC Health, and it's a sexual health clinic for anyone who lives, works, or plays in the District of Columbia. And we are co-located with our tuberculosis clinic as well. So DC is, obviously the nation's capital, and we operate in close conjunction with Northern Virginia and Maryland. So we try to accommodate anyone who is a district resident, but also those who may come into DC for work or for socializing or any other reason. And our services are free or no cost. And we offer a variety of sexual health services. So I'm going to focus a little bit on the testing that we do, and then sort of how that testing can lead to PrEP or PEP or other services. So we see about we have about 6,000 clinic visits each year, and we have a PrEP cohort of about 400 to 500 individuals. And we diagnose around 10% of the gonorrhea and chlamydia that is identified in the District of Columbia. Those are people who come through our doors. And most of our patients come from the highest HIV incidence areas of the District of Columbia, which unfortunately are concentrated in areas of less socioeconomic advantage, and areas that are predominantly people of color. So we try to be a very low barrier clinic for anyone who lives, works, or plays in DC. And we have a few ways that we can provide HIV testing. So one program that was launched around the pandemic to kind of serve people's needs as they were not able to engage in the medical realm as easily was the Get Checked DC program. And so this is an opportunity to allow people to go online to getcheckeddc.org. They can request either in walk-in testing through a LabCorp draw site or at-home testing. So they put in their information, they talk about what testing they want to do, and if they want to do walk-in testing, then we send them a lab order and they can go to any LabCorp walk-in draw site, which tends to have more generous hours than our clinic does. So people can go on in the evenings or weekends, and they can get their testing done there. And then those results come to us. And if there's any need for treatment, then we coordinate that in our clinic. The limitation there is that LabCorp currently doesn't allow people to do rectal or throat swabs for gonorrhea and chlamydia, which we're not sure why that's the case, because people can go into the bathroom to do their urine sample. So we're working on them with that, but that is one limitation of the walk-in testing. So then there's also the option of home testing. And again, as the pandemic kind of carried on, there's more interest in having accessible testing outside of a clinical setting, and it also allows some privacy. So in that case, people can do 3-site GC and chlamydia testing, as well as HIV testing. So these are some of the options, and the participation has been pretty great. So almost 4,000 DC residents completed walk-in testing last year in 2023. And we identified almost 80 cases of chlamydia and 17 cases of gonorrhea, and unfortunately 3 new cases of HIV that were able to be linked to care. And then a little over 1,000 individuals use the at-home test for STIs. The other great thing about this is, as others mentioned, is this can be a linkage to PrEP. So when you go online to order your testing, there's something you can click if you want a provider to call you to discuss PrEP. And so then we have a PA reach out to them and either do a teleprep appointment or set them up in the clinic. So that's one way to kind of make testing more accessible. And then, as Wes was describing, in Jefferson County, we have a similar model of an express clinic, which is also similarly very popular. People can come in and basically they just check off a list the testing they would like to do. They have to attest that they don't have any current symptoms or that they're not interested in discussing PrEP at that time, but then they don't need to see a clinician. So similar as to what was described, can come in and out, and usually people are able to complete the entire visit in about 20 minutes. And of course, that can be converted to a clinician appointment if anyone has any symptoms or any concerns. And so last year we had about 1,200 express clinic visits, utilized by a little over 1,000 individuals, unique patients. And we had a 4% positivity rate for gonorrhea and a 8% positivity rate for chlamydia, and also identified 1 new case of HIV. So, these are important so that people know their status, but then also important to connect people to other services, whether it's treatment of an identified STI or connection to PrEP or PEP or DoxyPEP. And, we try to think about other ways that we can get people the HIV prevention that they need. So another one of our projects that was supported by Componency is the PEP hotline. So it was created to address the needs for access to HIV post-exposure prophylaxis, non-occupational, that didn't involve waiting hours and hours in a ER just to get a prescription that you took to the pharmacy and you couldn't fill. And so this project was launched with Georgetown University in order to have a 24-hour, 7 days a week hotline where people can call if they think they've been exposed to HIV, talk directly to a provider, and then if PEP is indicated, they can go to a partner Walgreens to collect a 5-day supply of PEP that is free of charge. And then they come to the DC Health and Wellness Center for labs, follow-up, and connection to the remainder of the 28-day course. So we're able to, as described before, medication in hand makes such a difference. So people are able to leave with their whole PEP supply. And so that's been a really exciting program, really meeting people in the moments that they need it. It can be a really stressful crisis moment, and to have not only a warm person on the other end of the phone, but a kind of quick and efficient way to access PEP has been really meaningful for a lot of folks. And so in the first 18 months of the program, we initiated 407 people on NPEP. And then about 2/3 of those are completing their visits. So they complete NPEP and come for their follow-up visit after 28 days. And fortunately, we've had no HIV seroconversions in that time. And what has also been great is about 40% of those who initiate NPEP then transition to PrEP with us. So it's a really great opportunity to connect people to PrEP services. And we found, interestingly, that has connected more cisgender heterosexual women to PrEP than some of our other efforts. So that has been useful. And then also it's an opportunity to identify STIs. So about 9% of those who come in for their initial visit or follow-up visit are diagnosed with a bacterial STI, and we can treat and intervene at that time. And then, some of the other ways that we're trying to meet the needs of our patients and also connect them to HIV prevention services are through, more rigorous outreach for Mpox vaccination. That's another great time to talk about PrEP. And then doing DoxyPEP and trying to do DoxyPEP at some large scale events like the Mid-Atlantic Leather Weekend. We partnered with them, and we were able to provide about 400 starter packs of DoxyPEP and DoxyPEP education to the participants at that event. And using that as another opportunity to connect people to more continuity of care and sexual health services. So as we look forward, we are hoping to expand those efforts and, as described before, really emphasize and focus our efforts on continuing people on PrEP, expanding our injectable PrEP program, and trying to help our patients overcome the barriers that may prevent them from actualizing their HIV prevention. Thank you so much.
Thank you so much to all of our panelists. It's really amazing to hear about all the great work you all are doing. I just want to remind folks, please use the Q&A function or the chat to ask your questions. And while folks are thinking about what they'd like to ask, we had a couple questions that we wanted to kind of start off with. Just wanted to see if you all could share a little bit about some of the challenges that you've faced and how you've navigated those challenges or any lessons learned. Because, not all jurisdictions are getting this component C funding or additional funding that was mentioned. And so I think it would be interesting and important for those that are on the line that maybe in less resourced areas to kind of think about how they could maybe implement some of these activities.
I've got one example I can give. That's something that ended up being a fly in the ointment for my grand plans. I think I alluded to this in the conversation. In the beginning days, we were having patients perform self-collection of various samples. And that's something that I had sort of taken for granted. You go on the CDC website, you'll see multiple references to self-collection for many of these sexual health testing, especially, for NAT-based tests. That's something I think we made quite erroneously made the assumption that our lab was doing that or had validated for that. We probably did that for a solid year and a half. No, honestly, it's from inception. So it was 3 years that we were operating under that assumption. And then we sort of, what had happened is we were trying to share this process with the state. We got a sort of a emergency meeting request before a holiday weekend saying, we can't process self-collected samples anymore. Which was very disruptive. And I think I had just, and again, I'm not super in tune with a lot of the more detailed sides of lab certification. So I think that really, it's on me. I should have thought about this. But I think if you're thinking about trying to implement something that is involving patient self-collection, you really have to check with the lab to see if they have validated for it. And Dr. Harold, I think you had mentioned that the LabCorp had similar issues with maybe not being validated for self-collection, which to me was kind of surprising. I just thought that was something that would be done. So I think that'd be my cautionary tale to people is if you're thinking of expanding this, just check with your lab provider if you're looking to pursue a self-collection pathway for patients.
I think one challenge for our clinic has been being able to step back and see what we're doing, improve our programs. I think data management and analysis has been a big challenge for us, that, we're just running, seeing patients, keeping the clinic running, and also don't necessarily have an overlapping skill set to harness the data that we have and use our EMR effectively to say, okay, this many PrEP patients haven't shown up for 6 months. We gotta reach out to them. We gotta get to them. And I think that's something that we really want to focus on going forward. And I think when a program is started, if that is part of the creation, it can just really help with quality improvement and building the program, and identifying issues as you go, and identifying the challenges that your patients might have to accessing services. So that's something that has been, a thorn in our side, and something that we really want to improve on.
Yeah, I'm going to follow up on that. I think QI and QA are really essential parts towards all of this. And, we all are working in health departments. We all are underfunded. We all have seen the high turnover of what, COVID and MPOX. We keep forgetting the and MPOX part, right? Has done to our clinics. And that high turnover, you have to retrain people. You have to bring in new people. You have to make sure that they're aware of the systems. We've been very fortunate, especially, for example, with starting our PrEP program. Our PrEP navigator has worked in the county health department for almost 30 years. So she knows how to navigate the place, right? And she knows how to work things. But with the high turnover, especially in leadership positions, trying to make sure that they understand what your priorities are, especially if you have an outside leadership coming in, sometimes that can squash some of your hopes and dreams. But what I will say has been what is helpful is trying to be innovative around those obstacles. We have a great group of medical students and residents who want to do research projects, right? And so making sure that we recruit these people who are really excited to do some of this QI projects, to do some of these surveys, to see how and it provides them the opportunity to work in a public health environment that many of them are very interested in and might not otherwise get the opportunity to do so. So we've had quite a bit of success with recruiting some of these younger people in their careers, and trying to see if they can help us with a lot of the research in QI, because we can't do it all, right? We can't see all of the patients and make sure that all of the stuff is functioning and have all of the admin meetings and report all of the stuff to the CDC. I can go on and on. It really does linger. But again, I think those are the major challenges, is we're being pulled in so many directions with limited resources and already burnout and exhaustion from 2 back-to-back pandemics. So getting some new blood in there and making sure that you become innovative with what you already have and lean on the resources of people who know the system, I think that's what's led to much more success.
Thank you. I think one challenge I want to highlight, and a lesson that I think it brings forth for us, figuring out how to do PEP was initially quite complicated, right? And we talked a lot about how somebody does the financial assessment and who's the navigator, and what about if they're insured versus not insured, and patient assistance plans. And ultimately, it was actually easier and more straightforward for us to just purchase the dolutegravir. And we had then the generic TDF FTC, purchase 10 bottles with some of that money that came along that needed to be spent quickly, and see how it went. And one thing we wondered is, are we going to get overrun with people? Will there suddenly be tons of people coming in for PEP? And no, there were not. Like anything, you need to actually work to find people, but we were able to respond to the people who were in clinic. I think if we did some of what DC has done and really made it more broadly accessible in the community, more advertising, we probably would find more people on PEP. But it's interesting, I guess the lessons I would take out of that, first, just a comment. It's interesting how PrEP was initially like this too, right? And in some places still is, but it is now available as a generic medication and inexpensive. DoxyPEP has scaled up very rapidly, in part because it's an extremely cheap medication. PEP right now still is expensive. Either the integrase inhibitor will go off patent first, or we will decide to do 2-component PEP, as is done in some places in the UK, and there's some evidence to support, which I think would actually make PEP programs more accessible. But I think the lesson is that in many ways, I think you do just have to often start small and see how things go and build upon them. The starting is often the hardest part. And we can get caught up in trying to plan from A to Z. And sometimes you just have to start and get going. Krupa, I have a question for Rachel, which is a bit of a follow-on to the challenges. I can't figure, is that okay? Rachel, with the LabCorp program you talked about for testing, which is a really cool idea, how could you talk about how geographically dispersed LabCorps are and how hard was it to create that program? What were the main challenges?
Yeah, it was not that hard to create. So LabCorps, I think there are 8 in the District of Columbia, which is only 5 miles wide. So so they are geographically distributed in different quadrants of the city. And I think the hours really help, just because it's a little, even if it's not as geographically accessible, maybe someone could go after work or on the weekends when they couldn't come into our clinic. And probably the biggest challenge was creating the system, like the online system where people could go on and request which labs they were interested in. They give a little bit of demographic information so that we can track that. They of course say if they're interested in hearing more about PrEP. And then, we still, unfortunately, it's still a manual process on the back end. So we get that request online and then someone enters it into our electronic medical records, creates a PDF of the lab form and sends that to the patient. So that still is a little bit labor intensive. But it didn't create any need for like an MOU or a contract with LabCorp, just because it's like any other lab order that you could create. And we already have an existing LabCorp account because we have an in-house phlebotomist that's provided through LabCorp that we do all of our clinic labs through. So we were able to just add those tests to that account. So I'd say the biggest challenges were kind of creating the ordering system and making sure that that was communicating with us appropriately. And then it's still a little bit labor intensive to actually get the correct order to the correct person. But all in all, it's not too bad because it uses and takes advantage of an existing structure that the LabCorp site's already there. And I'll just answer a question I see here in the Q&A for DC NPEP. What medications are you using? Is the process different for insured and uninsured? And I would echo what Dr. Dombrowski said, that we have found that it is much easier to just provide all of the medication directly, but it comes at significant cost. So early on in the program, we were doing it so that we provided the TDF FTC and then created using the patient assistance program through ViiV so that people could go to the pharmacy and still get the Tivicay for free. And if they had insurance, then you could just do the copay card, which takes 5 seconds to do online. And then it's all free for them. They use their insurance, but there's no cost. And I think probably as we move forward and funding is more constrained, then we will probably try to use some more of those patient assistance programs for our uninsured patients and just give the full course of the medication out when it's kind of the highest priority or with a little bit more restriction.
Thank you all so much. Oh, sorry, Dr. Willeford, did you want to add something?
I was just going to say, so the way that we have ended up doing PEP at our clinic, we have relied heavily upon the drug assistance programs to help us with that. There's been we typically, similar to what I think what you were alluding to, we give out a 30-day supply whenever we see the patient. We do not have an on-site pharmacy, so we've had to partner with a local pharmacy who's more likely to have that in, and we typically send a prescription there. What I will say, the one thing that we've run into though is that when we get onto the patient assistance, we have to be very explicit with the company as to basically this is for PEP and not for the initiation of HIV medication, because otherwise I think, and I don't know all the details, my social workers briefed me on this, but I don't always retain all of it. But I know that basically once that approval goes through, the clock starts ticking on a 1-year window that you're able to receive that assistance, and you have to basically say this is just for PEP. It's not meant to be a long-term thing. And so she's had to follow back up with our pharmacy partners to let them know this, so it doesn't impact if they were to be diagnosed with HIV in the future.
Great, thank you. I'm going to go to one of the questions from one of our participants. They're interested in knowing what are some strategies that you are planning to use to help sustainability of your programs after funding runs out or funding changes.
Is Powerball lottery a fair answer?
I think it's very fair. I can comment on this a little bit, because I think this is one of the things that kind of haunts our dreams at night and keeps us awake at night, especially when we're re-upping on grants. And I know that my colleagues write a lot more grants than I do. It's exhausting, right? But the thing is that I think part of the success is building in very solid evaluation structures throughout the grant while it's there, right? So that way, when you are trying to re-up, of course, you have all of these accomplishments of what you were able to do, the innovations, all of these things. But let's say you don't get that grant again, then that information is there and can be present for you to go to other funders and try to figure out like, hey, city health department, county health department, this is how much we were able to do. This is how much money we were able to save for you. Would you continue funding this, for example? And I think also giving a face to the programs is very important, right? And I think showing the worth is really good. So again, we moved, part of our DIS structure right now is funded completely on component C. And if we don't renew that, then that becomes a little bit more of an issue. But we've already shown how much referrals there have been. We have already shown the utility of these. We've already shown the innovation, and already the county health department is already buying into a lot of this and saying, this is actually really helpful. This is really great. We would like to continue a lot of this stuff. So again, I think making sure that you have that built-in evaluation structure is of the utmost importance. And, brag on yourselves a bit. We're doing some great work out there, and people are being really, I think it's really amazing. It's so amazing to hear what everybody on this panel is doing, right? Like, I'm like, holy crap, I want to do that, right? So again, I think it's really helpful to share experiences and realize we're all on the same side here, and just try to make sure that we continue and hopefully continue to keep those funds, because again, nightmares.
We didn't get component C money, so we don't have that issue here, but I just wanted to offer a comment, and then Wesley, I'll let you say if this is true, but it strikes me that some of what happens when there's extra funding is it gives the time and the space and the bandwidth for people to really think and work on redesigning systems. And so it's not all just add-ons, right? The add-ons are very important, and that can be very difficult to sustain, and we'll keep working on that. At the same time, hearing about things like that express care model in Jefferson County Fast Track, now seeing 2,000 patients a year, you can't imagine putting that back into the clinic flow and having all the clinicians see those patients. It wouldn't make sense. So I think that's a really striking example of where the funding seems like created something sustainable.
What I'll say on that, because I applied for I think there was the recent application for sort of the successor for component C that came out, and and I'm basically the only one here working on that. So that was a lot of fun. But the good part about it, I think it gives me a moment to say, okay, I am spending several weeks thinking about our system and have the time, like you say, to sort of see the clarity of, okay, what can we do to improve our process? Because ultimately, like you're saying, it's giving you that time to just think about it, give you that time that otherwise you may not have, or may not have forced yourself to say, what is the best utilization of our resources? And I think that's one thing for us with like you said, with our fast track, the salary support was great. It certainly helped to accomplish it, but now we're in a position where, yeah, we're losing that salary support. Thankfully, our health department has seen the benefit of what we're doing. That there's been no question about continuing the line of funding that we have. So I think that, and then two, when we show just the amount of screening that we're able to accomplish now, I think that speaks volumes to our board of public health that we report to. So hopefully that is something that's going to continue to be just a pillar of our services, and I don't see that changing anytime soon.
Just one thing that I would add that we aspire to and we have not implemented, but I think is really so inspiring from some of the other clinics that we've heard about today, is allowing people to practice at the top of their qualifications. You know, that like DIS driven prep programs are in many ways more successful than a doctor driven prep program. And, you know it wasn't long ago that to get prep, you had to go to an infectious disease specialist, but we are not in that time anymore. It is so much more accessible, so much more streamlined. We know what we're doing. And so, having medical consultation available, but really allowing navigators, DIS, nurses, other people who are really committed to this cause to do a lot of prep is one way to streamline programs, potentially cost saving. And my impression is that for many patients, they get an even better experience just because of the connection that they build with the navigators and DIS. So I think that's one way to think about sustainability.
Yeah, I guess I have a follow-up question to that for all of you in terms of how were you able to get buy-in from current staff, and then also bringing in new staff with especially with like your clinics where you're doing express testing and things like that. Obviously, once you're in the process of doing it, it's quick and all of that, but setting all of that up takes a lot of work. So just curious how you were able to get buy-in.
Yeah, I think the inertia is real. Like in most health departments, I think many people are fine with the status quo. We also have express visits in the St. Louis County Health Department, but it also helps that we already had a walk-in model. All of our visits are walk-in, so it didn't really add much. It actually decreased some of the work for our MAs to do. And then again, because we were able to quickly assess, like the time spent, we looked at the difference between the time spent for express visits versus full visits. People realized how many more patients we could actually start seeing. And now we're going to start utilizing that for our prep patients as well, right? Especially if they're asymptomatic. So I think initially there's always going to be the knee-jerk reaction of like, but also we've really tried to work hard on utilizing the resources that are already present within our health department and the expertise that is already present within our health department. So again, our prep navigator has worked the health department for years and knows how to deal with it. Our head of DIS has worked at the city health department for years and knows how to deal with all of these things. It helps when people are already known by your staff and that they can trust because they already know what this person, how they act, what they believe in, how they work, all of that stuff. And so again, I think having the buy-in from community leaders, but also from leaders within public health, within your own systems is of the utmost importance to remove the inertia.
I also think people get excited, especially about a new modality. Like I think people get invigorated by something like DoxyPep. It's something new that they can offer to their patients. It's a new tool. I think people get excited about that. I think having a lot of collaboration from the beginning. I'm just thinking about launching our injectable prep program, and that was just like so many moving parts and logistically just tied up in knots. And I think, finding champions from within, talking about how it's exciting. It's like a new opportunity really gets people involved, and then building it from the beginning, but keeping everyone at the table when you're launching something new.
I'd say one thing I've benefited from with our, so, people know there's different subspecialties of disease intervention specialists. Of course, in my experience, the sexual health disease intervention specialists are fearless and quite ready to take on any new challenge. And that's really helped us make our changes possible, because I think our sexual health disease intervention specialists have seen the impact of a lot of sexual health issues, and they are very, very motivated to try to find new ways to address some of these issues. So that to me has been probably the biggest motivating factor that has helped keep us moving forward with a lot of our changes.
Great, thank you all. There's one more question from a participant. I just want to make sure we get to that, and then I'll see if anyone has any final thoughts. This question is about screening for PrEP. They're asking, is this being done in writing, like on intake forms, or verbally when the client is taken into an exam room? So I'm not sure who this question is directed at, but
I think it's for Joseph.
Yeah. So when we have the questions on our intake forms. So it can be on, we have like an iPad system where they answer the initial questions. Are you symptomatic? What are you here for? All of that fun stuff. And then at the bottom is those 3 PrEP questions. If they click yes on any of them, then we will automatically go and do a consult to our PrEP navigator. I will also say that my nurse practitioners have like a checklist at the end of each visit. Have you gotten a COVID vaccine? Have you gotten an Mpox vaccine? And are you interested in PrEP? So like they bop, bop, bop. And so it's, again, just normalizing this. And I think the change in the PrEP guidelines, of course, allowed us to do a lot more to make sure people didn't need to meet indications, right? They could actually talk to any person who's sexually active. And then what EMRs are you using? As I see another question, all scripts is what we have. I don't recommend it for anybody, but here we are.
great, thank you so much. Any final thoughts or anything else anyone wants to share before we're done for today?
Krupa, thank you so much. I guess I would just share, it's been exciting to talk about this work over the last few years in the clinics. And I think it's even more exciting to think what's coming the next few years, and the next iteration of funding like Component C does have more of a focus on community and reaching outside of clinics.
All right, thank you all so much for joining today. Thank you to all of our panelists, and we hope to see you next time. Have a good rest of your day.
Thank you all.
Thank you.
Thank you.